This video is presented as a teaching case for ruptured juxtarenal abdominal aortic aneurysm. This case will highlight key teaching points for learners at all levels. Imagine you're a resident seeing patients in our clinic. You are given a 67-year-old male with a history of a 5.9 centimeter juxtarenal AAA. Upon chart review, he had a past medical history of coronary artery disease, advanced CKD, hepatitis C, and current tobacco abuse. Prior to visiting the patient in the clinic, you pull up his scan. What are some of the key findings? This is a 5.9 centimeter juxtarenal AAA with a single mesenteric vessel as a common origin of the celiac and SMA. His renal arteries are patent bilaterally and his IMA appears occluded at the origin and reconstitutes distally. He has ectasia of the bilateral common iliac arteries and an occluded left hypogastric artery. He has ectasia of the bilateral common and superficial femoral arteries, as well as bilateral popliteal artery aneurysms, which measured less than 2 centimeters bilaterally. Let's pause here and review a commonly tested VSET question. What is the incidence of popliteal artery aneurysms seen with abdominal aortic aneurysms? And if the patient presented with popliteal artery aneurysms, what is the incidence of a AAA in the same patient? Alright, back to our case. So you go into the clinic room to see the patient. He tells you it's a known aneurysm he has followed for some years. He has no associated back or abdominal pain. So you get your focus history and you go to examine this patient. What will you be looking for? Of course, in vascular surgery, we want a full pulse exam, an abdominal exam to see if you can palpate the aneurysm, and in our institution, we have a pretty low threshold to do an open repair for a juxtarenal aneurysm, especially in a 67-year-old. So with that in mind, you go to examine the patient's abdomen and you see this. So he has a pretty hostile appearing abdomen. So as it turns out, his 5-vessel CABG was complicated by mesenteric ischemia, resulting in right colon necrosis with perforation. He had a right hemicolectomy, eventually converted to a loop ileostomy. He had a tracheostomy at one point, and eventually he did recover from all this, and he had his ileostomy reversed several months later. So are you still thinking an open repair? Maybe not, so you go back to your drawing board. What are some of the endovascular options for treating a juxtarenal AAA? And while you're thinking about that, I will give you some numbers here. So the paravisceral segment is conical, measuring 26 millimeters at the start of the visceral segment and widens to around 30 millimeters at the lowest renal, which is the left. The renal arteries measure 5 millimeters bilaterally. If you measure it just right, you can get an infrarenal neck length of 4 millimeters, and there's 1 to 2 millimeters between the common mesenteric origin and the start of the renal arteries. So we have an internal aortic conference at our institution at which we plan to discuss his case with a tentative plan for a 2-vessel EVAR with a scallop for the mesenteric artery. This is a little bit of a read my mind question, but stop and think to yourself, what is the limitation of this plan compared to other treatment options, including TAMBI or other off-the-shelf branch devices? So the limitation I'm getting at here is the production time for a Cook-Zenith fenestrated graft is around 6 weeks. So this is only an option in elective cases, and if the patient were symptomatic, you would have to consider an off-the-shelf device. Alright, so 10 days later, you transition to night call, and the junior resident gets a page. And I kid you not, this actually happened on this timeline. There's a 67-year-old male in the emergency department with back pain, a known AAA who follows with our clinic. So you go to see the patient and he is your friend from clinic. So he's coming back, he's had back and left flank pain for 2 days, which has acutely worsened tonight. Here are his vitals. He's normotensive, non-tachycardic. He's maintaining appropriately. He does have some flank pain and mild abdominal tenderness. He has palpable pedal pulses bilaterally. His lab values are as follows. He's got baseline CKD, no lactic acidosis, and his INR is 1.1. Here's a look at his scan. So you have a left posterolateral rupture that is contained with some retroperitoneal hematoma. So for the senior trainees watching this, I think this is a great scenario to think through ahead of time. You may be the attending on call when a patient comes in with a rupture that does not meet criteria for a standard EVAR. You need to take a realistic look at your own skill set and decide what you will do in that situation. Are you comfortable modifying a graft for a rupture? Are you going to try and lyse through some of these adhesions? Have a plan in your back pocket for this moment. Given his advanced CKD at baseline, we planned for a traditional EVAR device with planned coverage of the bilateral renal arteries, with a bailout plan to snorkel the mesenteric vessel if we could not achieve a seal proximally. So there are several described endovascular techniques for this, including Chimney EVAR, periscoping, and the sandwich technique. Although these are not standard of care for elective repairs, They can be used as a life-saving technique when needed. And there is some registry data behind this that published on 2-year outcomes of parallel stent grafting. Alright, so we have our plan, and I want to bring you back to the clinical scenario for a bit. As you are quickly trying to evaluate this patient, what are some of the key components of the story that will tell you how sick this patient is? Well, if you haven't heard of the Harborview scoring for Ruptured AAA, you need to look it up, and you can find a calculator on vasculator.net. But the key components of the calculator, I've highlighted them here. The patient's age, our patient is 67. The risk goes up as your patient's age is greater than 76. Of course, knowing if they are hypotensive, and the key number you're looking for is a systolic blood pressure less than 70. Their degree of renal dysfunction, so a creatinine greater than 2, and an INR of greater than 1.8 to evaluate for their coagulopathy. So our patient had a decent relative degree of mortality by this calculator here. And so now I've linked here the Houston Methodist Guidelines for Ruptured AAA, which is a pretty comprehensive and valuable resource to bookmark on your phone. This was actually published by one of our current residents when she was a medical student with this actually, and it's excellent, so please bookmark it now. Alright, so you have a rupture. What are some of the preoperative considerations you want to be thinking about while this patient is in the emergency department? Well, of course, if you're the resident, you need to call your attending. That's a given. Don't sleep on calling your reps either, though, and make sure before you talk to your rep they have some brief idea of the sizing to make sure they can be prepared as possible to help you. And we will go over sizing in a minute, but you also need to call the OR in advance in case some staff have to come in from overnight. Okay, so for sizing, how much are you planning to oversize your graft in a ruptured AAA situation? So in this patient, of course, we had a recent scan from when he was not ruptured, but in general, you want about 20 to 30% oversizing. Alright, so blood pressure parameters for this patient. Say this patient's blood pressure is 80/50. Are you going to give them a bolus, start neuroepi? Well, it's generally not the answer in this case. So there's something we like to call permissive hypotension, where we will allow for systolic blood pressures greater than 70. As long as the patient is mentating, we do not over-resuscitate in these situations. Alright, so what kind of access do you want? 2 large bore peripheral IVs, and bonus points if you can get an arterial line before the patient rolls to the operating room. Maybe you have a junior nearby who can help you with that. Alright, so some intraoperative considerations, and we're going to do this kind of rapid fire as we do in our case conference, even though that's more interactive. So anesthesia says to you, I'll do the central line after we intubate. What are you going to say to that? So no intubation, please. We will do this whole thing under local anesthesia, and this of course is to prevent any crash on induction. If you end up needing general anesthesia for cut downs in the groin, cut down in the belly, then generally you do this after you get some balloon control so you can stabilize the patient first and then you can put them to sleep safely. Alright, so you don't want a central line? Yes, we do want a central line, however this should not delay the case start. You can be working from the groins while the anesthesiologist is working from up top. This should not delay prep or the case start. This would all be happening simultaneously. Alright, so the circulating nurse. Doc, do you want a Foley? So yes, this is something that can be neglected, especially in high stress situations where the patient is unstable. However, this can be done after balloon control in an unstable patient and is very useful to have. So monitoring the urine output, you can guide your resuscitation. It's obviously needed in long and complex operations, especially if you have to convert to open. And it really doesn't take the circulating nurses that long to do. So yes, the answer is yes, you want a Foley. Alright, so you just want the groins prepped, right? We're going to do an EVAR. So no, the answer is nipple to knees for anything aortic, and this is of course in case you have to convert to anything open. In this situation, it's also useful to have the left arm out. As you know, this is a kind of a complex case anatomy-wise, and it may be useful to go from above. So you should at least keep that option open for yourself. Alright, so sheath selection for balloon control. This is something good to know as things are getting thrown onto the table emergently. So the book answer is a 14 French 45 centimeter. However, we generally use a 12 French. You can get away with it. And some of the Gore balloons are even lower profile at 10 French. So something to keep in mind. And finally, ProGlides and heparin. So these are very case dependent and attending dependent. Obviously useful to have the ProGlides in for pre-close if you're able to. If not, you have to cut down on the groins later. And for heparin, so if the patient is coagulopathic at all, it's generally not needed for these cases, but some people will heparinize after at least getting balloon control when they have bigger sheets up. Alright, great job. So let's move on to our case. This did start as a pretty standard EVAR. We have bilateral percutaneous groin access, which we pre-close using ProGlides. After that, we upsized to our 9 French sheets bilaterally, placed our stiff wires in the descending thoracic aorta, and upsized our sheath. Here we have our 32mm main body device going up the right side, which required an 18 French sheath. We have a pigtail up the other side, and we've taken our aortogram. You can tell we're in a near lateral position as we are planning to land our device just distal to the single mesenteric vessel. We selectively catheterize the mesenteric vessel and leave our catheter there so that after we partially deploy, we have safety access to that vessel. And after that, we catheterize our contralateral gate and extend, then extend our IPSI limb, and on completion aortogram, what do you see there? Well, you see that we still have a type 1A endoleak filling our aneurysm sac, so we do not currently have any seal. You can see from the lateral view here, it looks like the graft has slipped down along the posterior wall, and we did try and extend proximally using an aortic cuff. However, we still did not achieve a seal. So now what do? Well, it's a good thing that you thought to prep the arm. We actually decided to go with our bailout plan and snorkel the mesenteric vessel so we could extend proximally and achieve seal. So we've now cut down on the left brachial artery, selectively catheterized the mesenteric vessel from above, and placed an 8 French by 70 cm sheath. We exchange for a Rosen wire, and then we upsize our femoral access to a 22 French sheath and advance and deploy a Gore C-tag to extend proximally. So there's no data to support a balloon expandable versus self-expanding stent for the Chimney here. There are a couple of benefits to both, of course. We ended up choosing a Viabond for the flexibility and then extended proximally with the VBX. But we actually ended up needing to come back and reline the Viabond with a VBX due to narrowing of that stent graft. Because of this, we would recommend a balloon expandable stent graft for the Chimney as it can prevent compression from the other stent. So here is this final CTA, and you can see we have a good repair with a patent mesenteric snorkel and a small type 2 endoleak. There's no expanding hematoma. And the patient is actually still alive today and doing well. This case was done over 1 year ago, and of course he is dialysis dependent, but is doing well otherwise. So in this case, we discussed treatments for juxtarenal aneurysms, and a Chimney technique is a bailout. Remember, there is little how-to on this, and you may never actually do this in training. However, it is good to know about as it can be life-saving. Rely on your toolkit of skills. On literature review, there is a paper from 2022 published on outcomes of Chimney snorkel EVAR for symptomatic and ruptured abdominal aortic aneurysms. It was a retrospective VQI study that looked at CHEVAR in 77 patients. More than half were symptomatic compared to rupture, and over 70% involved snorkeling of more than one visceral vessel. This study reports around 18% 30-day mortality with a 13% reintervention rate, type 1 endoleaks in 11% of patients, and dialysis dependence in 14%. Overall, the authors conclude that this is an acceptable rate of morbidity and mortality for this very sick population. And here's a closer look at their outcomes if you're interested. Thank you very much for watching this video, and please subscribe to our channel.